Our next speaker is Dr. Brigitte Smith from University of Utah. Dr. Smith is my go-to person for any educational questions, so hopefully today she's going to be able to explain EPAs to us mortals here, so in a way that we can grasp what's going on. So, Dr. Smith.
I'm just trying to get unmuted there. There we go. Thanks for the introduction, Mel. I'm excited to talk to everybody this afternoon about Entrustable Professional Activities, EPAs. They were first developed in the Netherlands in 2005, so 15 years later, aren't EPAs gathering dust and sort of old news? Assessment alphabet soup or the future of surgical education, and certainly I hope to convince you of the latter. So what is an EPA? I'll start with a story to explain. This is my fellow, Dr. Jane He, and I was walking out of the hospital the other day, walking past the fellow's office, and Dr. He calls out to me and says, hey, the ED just called about a patient with a cold leg. And I thought about this for about a second, and I know Jane really quite well, so I said, okay, go and see that patient, and if they don't need to go to the operating room tonight, you can just call me in the morning and we'll talk about it then. And so what Dr. He was about to do was go manage a patient with acute critical limb ischemia, depending on how good your ED is or is not at identifying a true cold leg. And in this moment, I made a decision. I thought about, would I trust this learner to perform this task without supervision? So I considered things that I know about my trainee in terms of her competence, her knowledge and skills to perform the activity at hand. And I also synthesized that with my thoughts on her integrity, reliability, and humility. And I decided how much supervision she needed to do this task. Did she need to be observed, direct supervision, indirect supervision, or in this case, I allowed her to go ahead with unsupervised practice. And so that is it. That is how simple this is. That's what an EPA really is. It's a unit of professional practice that can be fully entrusted to a trainee once they've demonstrated the necessary competence to execute that activity unsupervised. And these units can be a discrete task like managing patients with cerebrovascular disease, or they could be a bundle of tasks like managing an inpatient vascular service. And these units are things that can be suitable for credentialing. And taken together, a list of EPAs are really the professional activities that together constitute the bulk of what it means to be a vascular surgeon. So how are EPAs related to the milestones that we just heard about from Dr. Velasquez? Aren't we just making all of this more complicated by adding another layer? Well, an EPA really requires proficiency in multiple of the different competencies and subcompetencies integrated all simultaneously at once. So when Dr. He was going to manage this patient with acute critical limb ischemia, competencies involved in that task might have been data acquisition about the patient, vascular imaging, would she order the right test and interpret it correctly, medical knowledge, procedural rationale, would she know, what the procedure would be that we'd need to do? Could she coordinate care for the patient, complete her admin tasks, and communicate with patients and the healthcare team about all of this? And so if you Google EPA and look at Google Images, you'll find some iteration of this diagram that really demonstrates that an EPA is the unit of activity, and it brings into it a variety of subcompetencies, and maybe not all of them. This activity, just off the top of my head, I included 10 of our 31 subcompetencies, and different activities might involve different aspects of them. So what might use of the EPAs look like? And I wish to convince you that EPAs actually simplify assessment. So EPAs simplify assessment because they enable us to shift our focus from all these individual myriad of 31, now 28 subcompetencies to the actual work that we do each day. And the assessment of an EPA is really by the level of supervision that's needed. So it's a very nice direct route to facilitating autonomy. They enable holistic assessment, integrating all the different competencies, and they're directly observable. Ad hoc assessments are made each day. Ideally, every time you interact with a trainee, they're doing a task. That would be one of our EPAs. And it's really not the same as the current end of rotation evaluations we all have to fill out. It enables us to do this more in real time with the interaction at hand. And filling out an EPA can be very learner driven, so it doesn't place burden on the faculty. So this is an example from the University of Alabama where they're piloting the general surgery EPAs, and they created their own app where the trainee would reach out to the faculty and ping you on your smartphone to say, hey, I did a surgical consult. Can you fill out my EPA performance? And then I would just go ahead and decide unsupervised practice. And what is built into the app here is that the milestones language is there for reference. So you can look at that and see all the different milestones that map to that EPA, and does that trainee really meet the expectations for competence for those things. So summative entrustment is where the rubber really meets the road here. And what we want to see is a portfolio of multiple different ad hoc entrustment decisions across many different conditions and contexts. And then a CCC could aggregate all of those decisions to make a summative decision about entrustment, generalizing permission for the trainee to enact that EPA without supervision. And this could look like progressive certification throughout training, and when a trainee has passed the appropriate threshold to do these things on their own. From that moment on, they would be trusted to act unsupervised. So the status quo seems to be working out okay. Why should we bother with something new? I think that EPAs for vascular surgery are important. It turns the equation to a partnership between the learner and evaluator, and it places emphasis on them seeking out evaluation opportunities. Asking the evaluator to assess about trust changes the framework of the conversation altogether, and provides clear anchors, like you saw in that app example, that allow for these decisions to be meaningful and substantial. With issues around surgeon and faculty burnout, we certainly, as Mal also alluded to, don't want to add burden. So we need to make this easy through mobile technology. And these are also some of the opportunities for EPAs that can reduce the variability of our training product, requiring people to be certified potentially in our core EPAs to be board eligible perhaps, which hopefully we'll hear Dr. Huber's thoughts on that in just a moment. It helps us to develop an assessment framework that allows trust around the core activities of being a vascular surgeon, which really aligns with societal needs. That's what our patients want from our trainees. It introduces more of a floor concept than a ceiling, a minimum level of competence or entrustment that everyone has to meet to be done, and allows for possible serial discrete credentialing throughout residency. So that could support advancement in training decisions and transition to practice. And with that, I'll thank you and look forward to questions during the panel.